think I will start and talk about the law, which will give you a little bit of underpinning so that then when Lisa talks about the practice, you'll have some understanding of where we're coming from and how we got where we are. And thank you, Mario, for inviting us. And it's nice to see so many familiar names, even if I don't see your pictures. Some of you are just very shy, but it's delightful to be here, and also with my very good friend and colleague, Lisa Stolarczyk. So let's talk a little bit about the law and how we got here and what it looks like. The definition of medical aid in dying, which comes from the Elizabeth Whitefield End of Life Options Act, is the ability of a terminally ill, decisionally capable adult to ask a willing, and I underline that, willing provider for a script for a lethal med that the patient can then choose to ingest or not ingest at their choice to achieve a peaceful death. So let's unpack that a little bit and talk about, first of all, what terminally ill means in the law. It means somebody who has had two clinicians affirm a terminal diagnosis with a prognosis of 6 months or less. It does not mean somebody with the dwindles or somebody who's 96 and seen all of their friends die and says, I'm done. You have to have a terminal diagnosis. It has to be affirmed by two clinicians, and those clinicians can be an MD, DO, nurse practitioner, or PA. We are the only state that has medical aid in dying that allows nurse practitioners and PAs to be full prescribers as long as one of the two clinicians is an MD or DO. And that's particularly important because we are a rural state, and many people, of course, receive their healthcare from a nurse practitioner or a PA. Then decisionally capable, what that means is that, of course, the person is able to make their own medical decisions. And we often get the question, well, what about dementia? I want to put this in my advance directive. If I don't recognize my spouse anymore, I want out of here. That is... No, not okay. The person has to be decisionally capable at the time that they make the request, and at the same time have a 6 month or less prognosis. So that if you are in early stages of dementia, you are still decisionally capable, no doubt, but you don't have a 6 month prognosis. If you have dementia and have 6 months or less to live, you are no longer decisionally capable. However, if you have a primary diagnosis, and I'm sure Lisa will talk about this, of cancer or something else, and you have mild cognitive impairment and are still decisionally capable, that's fine. So decisionally capable at the time that you request, and also on the day that you ingest, if you choose to ingest. This is really important because people's mental status can change as they reach the end of life. They may have brain mets, they may become delirious, they could be unconscious. So decisionally capable, both at the time of request and on the day of ingestion. What about self-administration? The law requires that the patient be able to self-administer the meds. This is not an injection. It is not an IV. It is a compounded substance that's mixed with some liquid, and it goes into the digestive system. So we use the word ingest. And so what we're looking for there is a affirmative, conscious, voluntary act. That's the definition of self-administration. Affirmative, conscious, voluntary act. So that could be drinking from a straw, from a cup. But if the patient doesn't have the strength to hold the cup, someone else can hold the cup for him because his affirmative, conscious, voluntary act is drinking from a straw, okay? And likewise, there are two other routes of ingestion, through a PEG tube or rectally. And again, the patient has to be able to, in either of those cases, push the plunger. That's all he has to do. Certainly does not have to mix the meds, doesn't have to insert a catheter, doesn't have to pour it into the PEG tube, does have to be able to push the plunger. But what if he doesn't have the strength to do that? We're not looking for strength, we're looking for intent. So if the patient can put his hand on the plunger but doesn't have the strength to push it down, someone can put their hand on top. So that's important when we talk about self-administration. Okay, so I mentioned that there need to be two clinicians, and one of them can be a PA or a nurse practitioner. One of the other important parts of our law that no other state has is if the patient is enrolled in hospice, the mere fact of enrollment counts as the second opinion, because the medical director of that hospice will have determined that, yes, this person has 6 months or less to live. This is hugely important. If you are in a rural area and you already have had problems finding one provider and then you have to find another one, this can take weeks, or in some places even longer than that, to get an appointment and be seen. But if you are enrolled in hospice, that serves as the second opinion. So we're very grateful for that. There's only, in our law, only one 48-hour waiting period, not 15 days as in most other states. And that waiting period is between the time the script is written and the time it can be filled by a pharmacy. And even that one tiny waiting period can be waived if the clinician, the prescribing clinician, feels that the patient is not going to live for 48 hours. And we've had that happen. One of the other things that did not come with our law, but is an add-on to our law, is that state-only Medicaid funds now will pay for the meds and for clinical visits. So if your patient is on Medicaid or is eligible for Medicaid, that's important because Medicaid will pay for those meds. If the patient is not eligible for Medicaid but is medically indigent, End of Life Options New Mexico has funds to pay for the meds for those patients. We have paid and we will pay, and it's one of the services that we offer. I will say that more than 95% of our patients are on hospice. And one of the things that distinguishes our practice, and Lisa will, I'm sure, talk about this, more than 95% of our at an ingestion, the prescribing clinician is at the bedside. We are so proud of that statistic. No other state can touch that. It is not in the law, it is not required, but our clinicians, our prescribing clinicians, step up and they are there with the patient and with the family. I want to talk just a minute about death certificates. People ask frequently, what's on the death certificate? The cause of death on a death certificate, if a patient has ingested MAID, is always the underlying disease. It is not this patient took MAID. And think about our COVID statistics. We've got almost 9,000 deaths. If 3,000 of those were listed as someone unplugged the ventilator, that would not help anybody understand our COVID death rate. We don't put unplugging the ventilator on a death certificate, and we don't put ingesting MAID on a death certificate. Likewise, the manner of death, we have three choices: homicide, suicide, or natural. Nobody is murdering these patients. It is not homicide. And the law specifically says this is not suicide, assisted suicide, mercy killing, or euthanasia. It is a natural death. I want to of course, emphasize that this is voluntary for both clinicians and patients. No one has to become a prescriber, but the law requires that regardless of whether you are a prescriber, there is a universal right to know. Patients have a right to know that this law exists and that this option exists. So if you're having an end-of-life conversation with a patient and you're talking about palliative care, hospice, VSED, palliative sedation, whatever, you are required to also tell the patient that medical aid in dying exists, and refer the patient to someone else if this is not a service that you are allowed to provide by your employer, or that you have a conscience reason for not wishing to provide. And I just want to end by saying today marks the 19th month anniversary since the rollout of our law. And despite what you might see on the front page of the Albuquerque Journal yesterday or the day before, we have had well over 200 ingestions in the state. We are amazingly proud of that. And my colleague, who's going to take over from me in 30 seconds, is the queen of medical aid in dying. So if there is a question that you don't want to wait until after Dr. Stolarczyk is finished, and I can take maybe one question, and otherwise hold it and we'll do it afterwards. Anyone have a question that wants to, I see that there are two things in the chat, but they're not coming across on my screen. So if someone has a question and you want to unmute yourself, fine. Otherwise, I will let Lisa have the floor. Oh, okay, good. I silenced you all.
We actually have a question from Chris Winterroud.
Okay.
Who asks, does the MSP, like QMB, pay, or would someone on Medicare need to have a full Medicaid waiver?
Okay, I'm not sure what the first initials are, so you're going to have to explain those to me. Medicare will not pay. There are no federal dollars involved in paying for Medicaid services. The Medicaid money is state-only money. There's no federal match for that. I'm not sure if that. Our family was among the 200, and I'd be happy to share our experience. Thank you so much. I hope you get a chance to do that after Lisa has her talk. Thank you very much for sharing that. Does that answer your question about Medicaid and Medicare? I'm not sure. I'm not an expert in either of those.
I work for the Aging and Long-Term Services Department. So we work with a lot of seniors, obviously. And for the most part, once people have Medicare, there are two Medicaid benefits. One is the Medicare Savings Program, which is a partial Medicaid benefit. I'd be really surprised if that helped. The other is a Medicaid waiver. That's a full Medicaid benefit that people can have in addition to their Medicare. And I'm just wondering if that might help pay, because one of the things, from my personal experience, I know how expensive this is. I mean, it cost an arm and a leg. Luckily, my mother-in-law didn't have an issue with that, but many of the people that I work with through the Aging and Long-Term Services Department would not be able to afford to utilize this option, right? So the idea that Medicaid would pay for it is it's great, but what specific benefit? I'm just trying to get an idea of what specific benefit that would be.
The benefit is the payment for the meds. The Medicaid has a direct pipeline to our two pharmacies, and Lisa will probably talk about this more. Lisa, do you want to respond to this question, or shall I just?
I can respond. The medication currently is costing about $550. So Medicaid people that are on have Medicaid benefit Medicaid will cover that cost of the medication. If people are not on Medicaid, then they are going to be responsible for coming up with the money to pay for the medication. I will say that at High Desert Hospice, for which I am the medical director, we are very, very dedicated to this program and end-of-life options. And our hospice in particular has set aside, kind of funds that are paid for out of the owner of our hospice own pocket on a sliding scale basis to help people who do not have money to cover that medication and are not on Medicaid.
Okay. So I think the answer is, the Medicaid pays for the meds. The cost for a provider is going to vary just as it would for any medical service. And if the provider accepts Medicaid for doing the eval and reading the records, et cetera, then Medicaid will pay for that. Okay. Lisa, why don't we turn it over to you, because I've taken more than my 15 minutes, I think. And if there are more questions, Mario, are there pressing questions that we want to answer now?
No, I think that's it for now.
Okay.
Okay, once again, I am Dr. Lisa Stolarczyk. I am the medical director for IDES Hospice. And as of today, our hospice company has completed 62 medical aid in dying at bedside ingestions. At the end of today, we're going to be at 63. And personally, I have done 48 of these. Next slide. So I want to introduce the American Clinicians Academy on Medical Aid in Dying's website. You want to go back one, please? Yeah. If you typed in Acclimate to your server, you would bring up this website. This has all the information on it that I will be talking about, and any information that you might be interested in that I won't be talking about. It was this particular website that I used and studied before I did my first ingestion with a patient. There's information in there for clinicians and for patients. This is also under the clinicians. There's a site in there where we file data at the end of one of our ingestions, and there are videos on how to do these procedures. This is a really wonderful source. Next slide. And so now I want to start by talking to you a little bit about what happens before we do an ingestion. Some of this is a little bit repetitive. As Nancy has already explained, patients in the state of New Mexico can be referred to hospice for this procedure. And the majority of the patients that we have done medical aid in dying ingestions for have been referred to us. We've only had maybe one or two patients from our own hospice that have elected to go into the MAID program. We do call it MAID for short. Patients, again, if they have a hospice diagnosis, then they also have a qualifying diagnosis for a MAID ingestion. And they have to have a 6-month or less prognosis. And as Nancy also said, the provider who has referred us is considered to be one physician or one provider who has determined that the patient has a prognosis of 6 months or less. And then once the patient is in hospice, it is like a person like myself or another provider that works with me that becomes the second provider. The one thing that I need to tell you is for this procedure, it's also very, very, very important to evaluate each of our patients that are potentially going to be a patient for MAID, to make sure that they are appropriate for MAID, not just appropriate with appropriate diagnosis and a 6-month prognosis, but we need to evaluate them using a red flag checklist, which I'm going to be going through with you. This helps us to make sure they are going to be strong enough or mentally have a mental capacity to go through this procedure. When I'm training people, I tell them this red flag checklist is best to be done the week of ingestion and definitely not the night before, because we can catch a lot of issues or problems by doing this red flag checklist that would help us prepare to mitigate any kind of risks that would be involved for a patient. We also send one of our hospice nurses. And by the way, I just want to say, if person is working for High Desert Hospice, an employee, and they are not comfortable with medical aid in dying or an end of life options law, and they don't want to be a part of it for any reason, we do not make anybody be involved. Only volunteer employees who really want to do this participate. And we have several really good nurses and chaplains that do participate, and now some nurse practitioners. So our nurse goes over sometime within a few days of ingestion, if they're going to be doing an oral ingestion, and we do a practice test, which we call a practice swallow test, in which we take 4 ounces of Ensure, because that's about the consistency of the medical aid in dying formula. And we teach them and coach them to drink this through a straw within 1 to 2 minutes, and we time it. And we counsel them that we don't want them to grab the cup out of my hand or a nurse's hand and chug it down really quick, because, and I've witnessed this, a patient did this to me, start choking. And that puts them at risk for aspirating, and that puts them at risk for vomiting up, a gag reflex to vomit up the formula. So we coach them against that, to just kind of slowly drink this through your straw within a minute or 2. And we also have the 2-minute time, because we don't want anybody to go past 2 minutes and then fall asleep and then not be able to completely ingest the formula. So I want to just tell you, the formula, the medical aid in dying formula, is designed so that if about 50% of it is vomited up or not, or somebody falls asleep, this happened to me, a patient fell asleep before they ingested all of it, it's still lethal. So there is some extra precautions we can take so that we don't ever have a patient that vomits this up or coughs it up or aspirates it. We are careful about that, but in case it happens, a patient is still likely to pass away. The other thing that we do for patients that don't qualify for an oral ingestion, we offer rectal ingestions. And for those patients that have masses or cancers or tumors that might be in that area, I had a patient just recently with an ovarian cancer with masses that did have tumors that were impeding the rectal vault. So I usually go over to see these patients myself and do a rectal exam. And if I'm not happy with my rectal exam, we will go ahead and insert a rectal catheter and fill up the balloon and tug on it and have the patient plunge about 2 ounces of water just to make sure that the rectum is patent. And I will tell you, I'm glad we do that, because we did have a patient fail that. And if we had shown up that day without knowing that we didn't have a patent rectum, then we would have probably ended up with a failed MAID, which I'm going to tell you, as of according to the people at ACMAID have told me to date, we have not had a failed MAID ingestion. But I think the reason is because those of us that do this are very, very careful with our red flag checklist and our exams. Then once we know a patient is now appropriate for, they pass the red flag checklist and are appropriate, we set a date and a time with the patient and their family. It may be also their friends. We've had all kinds of situations where patients just wanted to be just with their significant other, to patients that had a full-blown party while we were doing this. And then lastly, the most important thing is that we instruct all patients to be NPO, nothing by mouth, the night before ingestion. We do allow them to take medications. We allow them to drink clear fluids like water or clear apple juice, coffee or tea, but nothing with cream and sugar, because any food products that are in the duodenum or in the stomach at the time of ingestion are going to compete for absorption and increase the time for a patient to fall asleep and go into a coma eventually, and then to pass away. So that's really important. By the way, I'm just going to say here, the medications for the medical aid in dying, all of them except for one are absorbed through the duodenum, which is the first part of the intestine. Only phenobarbital starts to absorb in the stomach. So it's really, really important we get these medications into the duodenum for an oral ingestion or a PEG tube ingestion. Okay, the red flag checklist. First one, under gut issues, we need to make sure patients don't have any uncontrolled nausea or vomiting. And there are patients that we may not be able to control nausea or vomiting, and they are no longer a candidate for an oral ingestion. I will not do oral ingestions for any patient that's gonna have any issues with nausea and vomiting, because again, we need the medication in the duodenum so it can get absorbed into the arterial system to get to basically the brain, the brainstem, and the heart, which are the organs that we're trying to shut down. So those patients then go on to a rectal. The other one is severe cachexia, which happens in patients that have not been eating. This is very common for hospice end-of-life patients, especially cancer patients, or patients that are on medications that may cause them not to lose their appetite. So we have cells that work as transporters in our whole entire bowel, especially in our small intestine, and they serve as transporters. They're like little straws, I tell my patients, where food products and medications and fluid get from the bowel into the arterial system. These are called villi. And if you and I just stopped eating for one day, these would begin to atrophy. So a patient who has not eaten for weeks or days or weeks, it's like we're taking their straws out of their bowel system, and it just takes longer to absorb the medication. Another issue is gastroparesis. So sometimes we'll see this in diabetic patients or patients with nerve disease. This is just where the pacemaker of the stomach shuts down, and so now you have food products and medications just sitting in the stomach for hours and hours. We do use Reglan as a medication to help prevent this and help move this along. I have never had any problem with oral ingestions or PEG tube ingestions with patients that had gastroparesis because of the pre-medications we use. Severe constipation is another one that slows down absorption. So we do a pretty good job on doing fleet enemas and making sure the patient's having bowel movements before we do an ingestion. Partial or complete bowel obstructions, that kind of used to be a red flag to patient not even be a candidate for this. But we have now done 2 of these very carefully. They were risky. I had spoke to several other doctors before we did them, and they end up being very successful. So now we know, we've had other physicians in the country that have done these, and we are starting to understand that we can do successful MAIDs for patients with bowel obstructions. And the other factor is GI disease, such as cancer, any of the pancreas, colon, hepatic cancers. We still do those, but they can cause a prolonged death. So almost all of these things on this slide that I showed you, patients that we've done might extend a death from the average of 1 hour to about 3 hours. Next slide. Swallowing concerns is a big one. Any patient that's too weak to swallow or can't swallow are not going to be a candidate for an oral ingestion, but they may be a candidate for a rectal ingestion. Another red flag to think about are patients that are on high doses of opiates or benzodiazepines, and this is something that almost every hospice patient is going to be on because these are the medications we use for comfort. And this just gives tolerance to these patients, and patients that are using these medications and have been on them for weeks to months are also going to be, may experience a prolonged death. And the last slide on red flag checklist, under general factors, I'm going to tell you guys all of the prolonged deaths that we've had that have gone 8 to 10 hours have been patients that I've either had a very high cardiac fitness history, even patients that have been athletes even in their 20s, and now they're in their 80s and they haven't exercised in 30 years. Their heart is still really strong, and it just takes it longer for the digoxin to stop the heart. And I don't know if I have a real good reason for why, but I know I'm not the only doctor that has experienced this, but patients that have a history of alcohol abuse and illicit drug abuse, but mostly alcohol, you will see patients, or we have seen patients go on 8 hours before they pass. And then the mental health concerns, and Nancy touched on this. I'm going to tell you, this is a very important one, waxing and waning mental capacity. I have had to disqualify 2 patients because from the time we first met them and started working with them to the time we showed up, their mental capacity had changed to the point they couldn't sign an informed consent. We signed informed consent on the day of ingestion. So it's just really important to keep an eye on those patients that their mental capacity is fading. The other thing we've learned is we hold off morphine and benzodiazepines the night before on patients that are on those because sometimes those medications can make them sleepy. And then we show up and they don't know what we're doing, what their name is, can't sign an informed consent. And the inability to follow instructions is another one. We've had patients, I had one patient who is a breast cancer patient with metastatic disease to her brain. She had mild mental incapacity, just very, very mild, knew what she was doing, signed consent, but then had trouble following instructions. And that one was a nail biter, although she did complete her ingestion, but she had to be coached. Next slide. This is the 4 avenues. I know Nancy mentioned 3 of these. We use oral ingestion, rectal ingestion, feed tubing, and ostomy. My hospice group and myself have done all of these except for ostomy. So that one we would have to study and before we did one of these, but we have not had an ostomy yet. Okay, let's talk about the medications a little bit. Back up a slide, please. Thank you. These are the pre-medications used to mitigate nausea and vomiting. It's ondansetron, also known as Zofran. It's an 8 milligram tablet, and metoclopramide, which is also known as Reglan. 2 tablets of 10 milligram tablets, each for 20 milligrams total. That's 3 tablets that our nurse takes over to our patients. These we give to patients who are doing PEG tubes or oral ingestions. They give these medications to the patient 30 minutes before we do the oral ingestion. These aren't necessary for rectals. Next slide. And this is what the prescription looks like. We call this the DDM-APH formula. And that's because the first D stands for digitalis. The second one, D stands for diazepam. M stands for morphine. A stands for amitriptyline, and PH stands for phenobarbital. This is the prescription that we are using now currently. It is the best, and I just want to say one thing about this formula. This comes to us in a powder, and here it says we're mixing it in 4 ounces with apple juice or water. We are now collecting data on doing this, mixing this with 2 ounces, and our data looks really good. And I'm telling you right now, I no longer mix this formula in 4 ounces. 2 ounces, it works better, and it's less for the patients to have to deal with, to consume or plunge. There is a medication in there called amitriptyline, as you see. And this medication is really necessary for this formula. They tried substituting it out, and the formula did not work as well without the amitriptyline as it does with it. But that particular drug causes burning of the mouth and throat, and it also a very bitter flavor. So we mitigate that with oral ingestions by using a fat-free sorbet. Next slide. Okay, so this is what our day would look like when we have the family and the patients. Everybody's now ready. This is what we do when patients say, yep, I'm ready, let's do this. We mix the formula in water or clear apple juice. I did have a family member want us to use cactus juice, which turned the formula beautiful purple, and that was her favorite. We mix it now in, like I say, 2 to 4 ounces. I am now doing 2 ounces only. We mix it in a glass and then pour the mixture into a glass. It can, if you use plastic, the medication comes out of solution really easily and sometimes can adhere to the plastic. So you're just not getting as much of the medication into the patient. And we also use a straw. Every single one of these oral ingestions, we use a straw. And that is basically to prevent anybody from choking on us. And it works really well. Prior to giving the patient the straw to ingest the formula, we give them about a tablespoon of fat-free sorbet. Sometimes we have to give them some more while we're doing, we'll stop the ingestion and give them a little bit more in case they're really burning or having trouble with the bitter flavor. And then they'll get another tablespoon or so at the end. And this is really helpful. We are doing research, and they have pharmacists that are working on other medications that we might be able to use to help with the burning and help with the bitterness, but we don't really have that in protocol at this time. And again, once again, we do all these ingestions within 1 to 2 minutes. Next slide. And I just wanted to share, this is a table right off of the Acamade website of data that we did. This is data from October, so our N size is much larger than that. This is not statistical data, but you can see the trend. This is what the number of patients that we tried 4 ounces of mixing the medication and 4 ounces of apple juice, or mixing 2 ounces with a 2-ounce liquid chaser, or just 2-ounce suspension, which is the one I'm using. That's the number of patients and their time to death. And you can see time to death was lower in patients that were using the 2-ounce mixture. Next slide. Okay. So again, I'm just kind of showing you here, our nurse will arrive 30 minutes prior to ingestion to give the antiemetic medications or to do a fleet enema if we're doing a rectal ingestion. We have our patients sign informed consent on that day, and I complete all the paperwork that's required for the Department of Health. The Department of Health asks us to fill out 1 paper. It does not have any patient identifiers as far as their name or date of birth. It just asks for gender, age, the diagnosis for why that allowed them to do a medical aid in dying, the date in which ingestion occurred, and then I have to attest and sign that the patient self-administered. And then I think I kind of already told you guys this, that we then mix up the MAID and then perform the ingestion. And I will let you guys know, here are some statistics on the next slide. Statistically, and this also is what I've seen and experienced, the average time to sleep from the time a patient ingests to the time they fall asleep is about 5 minutes. We may have some that fall asleep 2 minutes and to 7 minutes, 14 minutes. The patient that was partying, who had a family that was partying, it took her 14 minutes to fall asleep. And that's just because of this extra stimuli that was in the room. The average time to death, and this is what we are seeing in our hospice, and this is also national data, is 1 hour. I will tell you that our statistics, our shortest time to death is 7 minutes. Our longest time to death was 10.5 hours. And I know from talking with other providers in the nation, this data from the nation is about, we had a patient that did die while they were consuming the ingestion, while they were drinking it, and the longest time to death was 2 days. And I just wanted to state again, we have had no failed ingestions to this date using the DDMAPH formula. Next line. So this is, I'm not going to go through this in any detail, just to let you know that we do collect data for all of these ingestions. So we keep these numbers, these things that you're saying, we record the time it took to sleep, the time to death, the zip code, the gender, the age, and the hospice diagnosis. Next slide. We also collect how the MAID was, which mode we used, whether it was oral feeding, rectal, or ostomy, and then how many ounces we've mixed it in. If the patient was able to tell us if it was bitter or burning flavor, we let them know that. Whether they had any kind of risk factors on the red flag, all this stuff goes into a database that we keep. I mean, we're aiming for 10,000, an N of 10,000, so we have true data for statistics. And then I think this is the last slide. That we enter the data into the data filing system of the Acamade site. Our nurses call the funeral home. And then, of course, our hospice team is available for any bereavement support for the patient's family or friends. So now I'm going to leave it up to questions, and then we'll have Chris talk.
No questions? Are there some in the chat, Mario, that you'd like to share with us?
No questions currently in the chat.
Okay. Boy. You want to go, Chris? Tell us a little about your experience.
Sure. Basically, first of all, I can just confirm everything that Lisa just said. My mother-in-law was actually a longtime hospice volunteer. She was Hospice Volunteer of the Year once. I have her award in my couch. So, I mean, in my house. So she was very well aware of what it might look like for her when she was diagnosed with pancreatic cancer. And it was exactly a year ago that she got the diagnosis. I was with her when she got the diagnosis. And, I am going to be emotional. I was not expecting it, but here we are, right? So let me know if I'm rambling or you need me to talk about something different. She looked at me and said, I'm not going to fight this, right? When she got the diagnosis. So she was crystal clear from the beginning. And through my work with the Aging and Long-Term Services Department, I was aware of the MAID law because I'd worked with people around this, but it was hard, and it took us a lot of work to find our way to how to do this, how to access the providers and the services. And I think we talked to both Leah and Nancy. You both sound really familiar to me. My sister-in-law, I mean, we worked together as a family to help my mother-in-law access the resources that she needed to do this, because it was clearly her wish from the beginning. She first consulted her pastor.
Okay.
Her pastor she is the best pastor in the world. Her pastor didn't immediately respond, but actually checked with the bishop, right? So that she had full and complete clarity for herself on this. The hospice organization that she was with, and I don't know if things have changed, it was Visiting Nurses of Los Alamos Visiting Nurses, and they did not, they weren't like yours, Lisa. They did not provide support for this. Her hospice nurse was awesome. So by the time we wended our way through the process, it took a couple of weeks, and there was not unanimous support amongst the family either. I don't imagine that there always is, right? So, but she was clear.
I remember your mother-in-law.
I
remember your sister-in-law.
Nobody ever forgets her.
When you said Los Alamos, you didn't have to say any identifiers. I remember your family. Okay, go ahead. Yeah. I'm sorry.
And we were, so we were just so grateful to find the support and to get that assistance through the process. I mean, my perspective as a family member who's been through this is that, it was difficult to connect with the resources. And, I'm on a little bit of a tightrope because people are still uncomfortable with it, right? Just generally speaking in public. And I've actually talked to my boss about how do we, I mean, because I work in the Aging and Disability Resource Center, it seems to me that we would be the first place somebody would come if they, or they should be able to come, and we should be able to guide them to the agencies that they need. And our experience was beautiful. Okay. We had, 3 of her 4 children were there at the time of death as she went through this. In-laws, grandchildren participated by phone if they weren't able to be there in person. The hospice nurse was there because she wanted to be able to bring that experience to her organization, and we were happy to welcome her to share this with us. Her pastor was there, the doctor was there, and everyone at the end said, that was amazing. I've never seen anything like that, right? We were able as a family, because we knew this was coming, everyone was able to have their closure. And so, this is clearly something that I support as both a family member and, as I can't speak obviously for the New Mexico Aging and Long-Term Services Department, but if there's anything that we can do to make sure as the logical resource for people to go to for information, I'll make sure it's there.
Thank you. I appreciate that. And of course, End of Life Options New Mexico is a resource, and your sister-in-law, I think it was your sister-in-law,
Yeah.
took the cat to California afterwards, was my primary contact, and that hospice. I had spoken with their board. One of our local oncologists had spoken with their board to try to get them to become a participating hospice, to allow their medical director, comparable to Lisa. No one is comparable to Lisa, but their medical director, to prescribe, because she was willing to prescribe, and they were not willing to pay her to prescribe. And the message from that hospice was, doctors don't come cheap. So the number of hours that you may recall Maggie Wilson being with you, who drove up from Albuquerque, bringing your medicine, whatever, that hospice did not want to pay their contractual medical provider. And I'm giving you this background because each time we have an ingestion, it's unique. Here's a lady in Los Alamos. She's involved with this particular hospice. We try to get them to be as open and progressive as possible, and they only went but so far, and it wasn't for lack of trying, and they still have not crossed that line. And then we have High Desert Hospice, that 64 ingestion, where Lisa or her colleagues are there. So yes, I really appreciate hearing your story from your standpoint, Chris, and your memories. And I know your mother-in-law was one strong lady.
She was.
She knew her mind, didn't she? Yeah.
She did, and she was crystal clear. My brother-in-law in particular had a really hard time with it. But her wishes were her wishes, and we all supported it. And I'm very happy to be able to share that there aren't lingering issues in the family because of this division in the support for her choice to do this, which I imagine that there can be sometimes, but there aren't with our family. And that is, I think partly due to the fact that we were able to really consciously address things and, have that closure. We had a dinner. We had a dinner the night before. And my brother-in-law showed up unexpectedly. He was not going to come. He got in the car and drove down from Denver at the last minute. And we all had that one last family time around the table, including Anne. It's the first time she'd been out of bed. And it was, it was magical. It was magical to be able to do that.
Mm-hmm. I remember hearing about your brother coming from Denver, having dinner, staying overnight, saying goodbye to your mom, and leaving before the ingestion. How beautiful is that? He couldn't bring himself to be at the ingestion, but he said his goodbyes to his mom, and he was with the family. So, I talked to an awful lot of people, and I remember those details very vividly. And your family was amazing. Glad we could partner with you to make that happen.
Me too. Thank you.
Thanks, Chris.
So we have two questions in the chat. The first question is, what are some of the cultural aspects that have come up when doing this? As a medical team, what has been done to be culturally aware or competent?
Nancy, I think that's probably a question that I will discuss, but then maybe you might want to jump in.
Okay.
We really don't have any cultural training as a hospice staff, but we have been doing hospice I've been doing hospice care with them for over 8 years, and we've had every religion and culture that you can imagine that here in New Mexico. Our approach is our patients' family. It's kind of the family and the patient's decision on whatever they want us to do, we do, and we honor. We honor all any of the religious requests that we've had, or any of the culture requests. We just basically do what they ask us to do, and we think that's important that we do that. Okay.
I know that as with any new concept, there are early adopters, and then there are those who come on board later. This is a new concept in New Mexico. It's been around for 25 years in Oregon, but it's new to New Mexico. And what we are seeing, and I think they did print that in the journal article yesterday or the day before, that most of the people who are requesting medical aid in dying are Anglo. This should not be a surprise. Those are the people who are reading about it and asking about it and are challenging their medical providers to give them the service they need. And if the medical provider says no, then they go on and find another medical provider. But I will tell you, certainly we have had, as Lisa said, every group. We have helped undocumented immigrants. We have helped, whatever, every religion and no religion. And so it is spreading. And we are learning along with the people who ask us about this. And we have Spanish-speaking providers who have been at the bedside, et cetera. So it's a work in progress. We're not saying we're there yet, but we're trying to be aware and to meet people where they are and give them the service that they're asking for or wanting.
Okay. Excellent. And then
thank you, Gabriella.
Go ahead.
I was just thanking Gabriella for her question. It was a very good question.
Yeah. Okay.
Excellent. And the final question is just, can you briefly go over whether or not most medical providers charge for these services? And if so, are any insurances covering the costs?
That's an excellent question. And it goes all the way from pro bono. We have one provider who is totally pro bono. And then we have providers, private providers who are charging as much as $2,500. But even those providers have provided this service for individual patients pro bono. They don't say this is my fee, and if you can't pay it, good luck. it really varies. And then, of course, there are those providers who are employed by a hospice, and it's part of the hospice service. And for those patients, there is no fee. So we have 2 hospices in Taos. We have a hospice, obviously a large one in Albuquerque, with more coming on board, a hospice in Las Cruces, and then, of course, private providers who provide either geographically, or some of them will get in their car and they've even stayed overnight in motels in remote areas to help patients in those areas.
And Nancy, that's pretty much what happens nationally as well.
Right. We have not turned down anyone who has called End of Life Options New Mexico and who is eligible. We will connect them with a willing provider, and we've not had anybody say, oh, you know, I can't help you, or the person say, I'm not going to have that service. So I think we can feel very proud, and our numbers, 228 as of about an hour ago, are off the charts per capita compared to any other state that has medical aid in dying. And it's thanks to people like Lisa and other providers around the state.
Excellent. Well, I want to thank you all again for attending today, and we hope to see you again.
Thank you.
All right, thank you, everybody.
Thank you for inviting us.